thank you very much for inviting me to come and talk to you today about orthopaedic surgeons and Paget's disease and what we can do to help patients with symptomatic disease that is appropriate for orthopaedic surgical intervention. So just to cover what I'm going to talk about today, we'll talk about what are the bone changes that we see in Paget's disease and how do they give rise to symptoms that might come to an orthopaedic surgeon, and what does an orthopaedic surgeon do about it once he actually sees it, sometimes. So just by way of sort of background, although you've had a lot of information from Stuart about the basic biology of Paget's disease, I'm just going to cover some of that again because it's relevant to orthopaedic surgery and how we deal with the problem. So, as you know, bone is always turning over throughout life, and it's there to this turnover is there to repair minor damages that occur to bone throughout life, to accommodate growth and development, and to also control the amount of various minerals that we have floating around in our bloodstream. If we imagine, does this work? Yes. So if you imagine this is a normal bit of mature adult bone, and then throughout life we get these little packets of remodeling activity that occur within the bone. So if you can see these sort of little blue ring octopus things coming in here, these are osteoclasts, so they're bone cells that take away bone. So you can see they're digging a little pit here in this bone, and then once they've done their work, these kind of little sort of look like moon jellyfish sort of come in here and start putting bone back, and this is new bone that's being formed in the hole, and this is occurring throughout life. But in Paget's disease, something goes wrong with this mechanism, and we get too many of these fellas coming in into the situation, into the local environment. And because instead of having just small numbers with doing this turnover, we get lots and lots of this activity all going on at once, and this results in the bone being formed being very sort of disorganized, and this is one of the characteristic features of Paget's disease. And so if we look here on an image, we can see this is what the honeycomb structure of normal bone looks like, but in Paget's disease you've got lots of bone taking away and bone adding activity going on, which leads to everything looking sort of rather thickened and a bit more like a Weetabix than a nice normal sort of bone presentation, bone appearance. So in Paget's disease there is this classical transition through three phases of the disease. Early disease, which is we call lytic, where you get a lot of this osteoclastic bone resorbing activity going on. That's imaged to sort of here, or it's a sort of cartoon representation. It's not literal, by the way. And then we get this kind of mixed phase, where you see lots of osteoclast activity going on and lots of osteoblast activity at the same time, and then later on we've got this kind of sort of late sclerotic phase, where the predominant features are where you've got lots and lots of new bone formation. But in reality all these things are occurring kind of often simultaneously in an individual, and this gives rise to the classic bony features that we see illustrated here in this sort of typical image of the patient with advanced Paget's disease, and I'm going to go through some of these symptoms as they relate to bone in the next few moments. So Paget's disease, one of the first things we do if the patient with suspected Paget's disease is to get a bone scan, and what we do with the bone scan is you inject some a small amount of radioactive material into the bloodstream, and that homes to bone because it's attached to a bisphosphonate, which we've heard about earlier on, and then you get a gamma camera and take a picture of it immediately after, and then after a few hours, and it lights up basically where you've got new bone being laid down, because it sticks to the sites where there's new bone formation. And so in Paget's disease we know there's a lot of this because there's this high bone turnover rate that we talked about before, and so it lights up basically on the scan. And in Paget's disease with a bone scan you can see the different classical features of the disease. One is that you can either have what we call disease affecting just one bone, which is monoostotic Paget's, or you can have Paget's disease which affects several bones, and we call that polyostotic Paget's disease. Some things that you'll notice on this scan, on these scans, is that when Paget's affects a bone, it doesn't cross over the joint between the two bones. It just affects the bone that it's kind of involved. So it's almost like it's isolated to that. You can see that in an example here, and you can see this thigh bone is affected, but note in this patient the pelvis is not affected, neither is the shin bone. But in this patient, only the shin bone is affected here. So it doesn't cross joints, which is one of the features that we use to know that it's Paget's disease rather than something else more unpleasant. So what sort of problems can Paget's give you? Well, most patients with Paget's disease don't have any symptoms. Although Paget's is quite prevalent in the UK, about 1% of people over the age of 55 have Paget's disease, and the incidence doubles with each decade as you get older. But most of these patients are, or most of these people are asymptomatic. But when we get problems with Paget's, the number one problem is pain. Exactly, yes. And pain can either be from the bone itself or the related structures, and we've heard about the complex nature of pain from the previous talks, and how we're trying to better understand what the complex nature is. And you can also get pain from the joint, and joint is most commonly wear and tear arthritic type symptoms. Now, it's important to note at this point that osteoarthritis is extremely common. Something like 40% of the over 70s in the UK have symptomatic osteoarthritis in one joint or another. Paget's disease is also relatively common, and to be honest, common things being common, they commonly coincide, although the deformities around the joint that Paget's can give you can exacerbate the risk and progression of osteoarthritis. So we've got this bone pain and joint pain, and then we heard before about deformity of particularly of long bones, like the thin, like the shin bone and the thigh bone, but also the bones in the arm can get deformed as well. And we heard that because the bone is turning itself over very quickly, it's actually quite soft, and that's why you get the deformities, because the bone isn't used to resisting the normal sort of weights and strains that go on in life, and so you can get deformity of the bone. And of course, deformed bones are also by their nature, just because they're deformed, not because of the fact that the bone within them in Paget's is not is this woven type of bone rather than a normal bone. You have an increased risk of fracture because you have higher stresses at places where bones are being sort of bent out. Well, if you want to break something, the best way to break it is to bend it, isn't it? And then you get very high stresses on the tension side, and the thing eventually snaps. Well, the same happens in Paget's bone. Other features, other symptoms that patients can present with in Paget's is those due to nerve compression. And usually what happens is nerves get compressed in Paget's where they go through narrow gaps in the bone or narrow holes in the bone to get to the outside world or to get to the outside patient. And at those points where the bone has got deformed with Paget's, you can get nerve compressions, and that causes symptoms of pain. And then at the bottom here I've got bone cancers, which is very, in fact it's not actually on this. It does say at the very bottom it says bone cancer. I can see it on my screen. Maybe it's a thing of the, but anyway, don't worry about that at the moment. So deformity, I'll just take you through some. Here's an example of a bone that's normal, and then here's a pagetoid bone. You can see that there are areas of where it looks very dense, the bone, and areas where it looks very sort of see-through, and this is typical of this kind of pattern with Paget's disease. And in this shin bone, you can see the deformity progressing over time as the soft bone bears weight. It starts changing shape, and in very severe situations you can get very bent bones, and this is a condition that we call saber tibia. Here's a little bit more more typical sort of pagetoid shin bone. You can see the deformity progressing over the years, and ultimately this can lead to fractures, and you can see a fracture through this shin bone here. Here's a fracture through the bone, long bone in the arm, the humerus. There's a fracture there, and there's a fracture here, and here is a fracture just below the ball and socket of the hip. So that's what we call a subtrochanteric fracture. And there are actually 3 fractures here. There's one complete one here, and there's 2 that have gone on to, that one's united, and that one's kind of a partial fracture that's trying to heal. And the way that we deal with these fractures is the way that we deal with all fractures. And that is to correct the deformity so that it's structurally going to last, and fix the fracture till it heals. And the interesting thing with if you get a fracture through pagetoid bone, it does heal, and it actually heals by producing what looks more like normal bone. That's not a solution to Paget's, by the way, just to break every bone in your body, but it's just a curiosity. So here's a pagetoid fracture here, and this is the way that this has been fixed in the shin bone with this thing called an external fixator. And what you can do with this is, because it's all this thing is all held together by wires, then there's rings all the way around here, and then the rings are held together by rods which are slightly out of the imaging here. And what you can do is the rods have got little screws on them, so you can actually change where the position of the rings. So if you start off with a deformity like that, you can gradually crank things out so that it's all in a straight line. And that's what's been done here. So you've got a fracture down here, and then what they've done is they've actually created another fracture here so that they could actually straighten the bone out right the way down its length. And so by making the bone straight, it's actually taking load directly in compression instead, and that's much stronger. You know, if you get a toilet roll or a kitchen roll, just the inside cardboard bit of it, and if you try and press down, it's harder to break it than if you just grab the ends and do that, in which case it breaks quite easily. So you can see how deformity is a real problem causing weakness in bones. So what about joint pain and arthritis? So typical joint pain that is due to wear and tear arthritis is usually worse with activity. It's very focal in nature. It's rather than being diffuse. It can affect a particular part of the joint, say the inside of the knee, if it's knee arthritis, or the hip. You can get pain in the front or at the back of the hip joint, and it typically, as it progresses, often starts to disturb sleep, and then once your sleep's disturbed, you get pretty miserable. And that can make you have different psychosocial perceptions of the pain. And arthritis also can affect people's lifestyles, work, domestic, social activities. And in the management of these patients, we always liaise with metabolic bone services, and I'll come on to why in a little bit later. So here's an example. Can everybody see this pelvis okay? It kind of looks a bit bright on the screen. Here we can see the Paget has affected the top of the thigh bone here. There's no Pagets in the pelvis at all. It's all in the top of the thigh bone. So if you see a picture like that, you kind of, sometimes you might be thinking there's something else going on, but what tells you it's Pagets is the X-ray and the fact that the disease is not crossing the joint. At least the Paget's disease isn't, and we'd usually get a bone scan anyway in patients with a diagnosis of Paget's to see where else they've got it as part of characterising the disease. This patient's also got osteoarthritis of the other joint here, which is completely non-pagetoid. So probably this disease is actually just coincidental. They've got arthritis in a joint that happens to have Paget's disease in one of the bones. Here's another example, slightly different. Here the Paget's is all affecting the pelvis. So you can see typical Paget's disease appearance. You also, another thing that tells us that this is Paget's and not another type of bone disease is that the actual bones are bigger than they should be. So this half of the pelvis is actually slightly bigger than this. So you can you see that shape is different because the external margins have got pressed out, and that's one of the features of Paget's. And here you can see this bone, actually the top of the thigh bone has not got any Paget's in it at all, and probably here the disease progression was that the Paget's disease was contributing to the development of the disease of the arthritis. And so total hip replacement, the operation of the century, as described in the Lancet maybe about 15, 16 years ago. Very effective for treating arthritis, very good results, and the results are just as good in patients with Pagets as in patients without Pagets. There are lots of different types of hip replacement that we can put in. We can either put them in with glue, as in this one's glued in here at the bottom, or you can put them in without glue. And generally in Pagets I tend to put in one with a glue because it makes the bleeding less. And one of our concerns with Paget's disease and operating on patients with Paget's is that because there's lots of bone turnover going on and there's blood supply to the hip joint is very good, it can actually be a bit of a bloody procedure unless you liaise with your friendly local metabolic bone physician to control the disease before we do the operation. So what we like to do, you can't see it says at the bottom actually, normalise bone turnover before surgery. So what we want to do is actually get one of the markers, what we call the alkaline phosphatase, get that down in the normal range so that we assume then the blood turnover, the blood flow is reduced, and so it's safer to operate. And here's just a schematic in case you want to go home and do a hip replacement yourself this evening. So just to tell you what's involved. So here we'll make a cut on the thigh bone, and we cut off the neck of the thigh bone just below the head, and then that gives us access to the socket part, and we get a little sort of drill business and ream that up, and then we put in here's a cup that's just been here's one I put in earlier. And then we just do the same thing for the thigh bone. Now the thigh bones were specifically designed with a hole in it so that you could put a joint replacement in it. So that's what we do. We use the hole that was there for the hip replacement, and we go down inside the bone and put in the thigh bone part of it. Simples. And now if you want to go home and do a knee replacement, here's a quick example of how we do this. So you can see the arthritic joint here, and what we do is we cut off the bits of the bone just lining the cartilage and replace them with a knee prosthesis. And these have equally good survival to joint replacement, to hip replacements. About 90%, 20-year survival is what we expect from the average joint replacement, and it's no different in Paget's to any other arthritic disease. And here's another one that I did earlier. But in Paget's we have the specific problems because the bones, as well as the joint being diseased, if the bones above it and below it are deformed, then we've got to deal with that because like anything in bones and joints, you've got to get it straight if you want it to last. And so here's a patient with a deformity here above arthritis of the joint, and so what we want to do is actually, instead of having this thigh bone being this shape because of the pagetoid deformity, what we want to do is actually make it back into a straight bone, and we do that by taking a little wedge out about here and then putting the knee replacement in and having a long bit going up the thigh bone there to control it. And it's also held with a little plate here, and that allows the fracture to heal. And if you remember, fractures in Paget's if given the opportunity, will heal by making normal bone. Now, usually we can do this with variations on standard implants, but occasionally we have to get a custom prosthesis made because the patient's bone shape is dictating it. And that's really about getting it to hold into the bone at the relevant points. So we've talked about peripheral joints, hip and knee. Now I'm just going to go on to the central bit. I mentioned before that you can have problems with Paget's both in the skull and in the spine, and you can see here's a patient who's got progressive Paget's disease over many years, and you can see the thickening of the bone. And in Paget's disease of the skull you can get a headache is one feature, and that's in part because the box is slightly smaller than it's meant to be, and that can give you a headache. You can also get compression of the nerves that run out of the box, so the nerves for hearing, the nerves for skin sensation over the face, they all come out of little holes in the bone, and if the bone is abnormal, as I mentioned before, it gets bigger as well, and that makes things tighter. and that's where you get the nerve compression. And if we go on to the spine is the second most common site for Paget's disease, and back pain is very, very common. And the back pain can be due to the disease itself, although we know that there's no clear relationship between whether the bone is turning over fast and the pain. It can also be due to damage of the joints and also nerve compression symptoms. So, as I said, it can be due to the disease itself, and there's lots and lots of little joints in the back, and they can get arthritic because of the Paget's disease, and that can give you mechanical back pain related to arthritis, and you can see that here. You can also see, can you see how narrow that little tube is? And that's the tube where your main spinal cord runs down. And when that gets squeezed, that can give you symptoms. And if it's squeezed in the middle, it can give you symptoms of backache and numbness and weakness in your legs, which is a kind of, and it can be quite insidious, so it can be a very subtle sort of feature. And also it can give you symptoms where the nerve comes out of the hole, just like nerves coming out of the hole anywhere else in the body with Paget's. And so here actually the Paget's has caused, this is a slip of one bone on another, and that's because there's a little fracture that's developed there because the bone's been abnormal with the Paget's disease. If the cord gets very, very pressed with Paget's disease, you can see some tight narrowing here and some tight narrowing here, that can give rise to significant problems with legs and with bladder and bowel function. And that can be treated by taking out the pagetoid bit and putting bone graft in and a little replacement of this block of the bone in the back. Lastly, osteosarcoma or bone cancer is very uncommon in Paget's disease. I've been a consultant in orthopedics for 15 years, and I've never ever seen anybody with Paget's coming with osteosarcoma, but I've seen a lot of patients with Paget's. So it is very, very rare. And what you see in here is that things are slightly different because you start seeing these different features in the bone. You can see, I don't know if you can see from a distance, these little spicules almost coming out from the bone. That's called sunray spiculation, and we see this unusual sort of periosteal lifting. And here's another example. It's just gone a bit too bright on the screen to see the same thing. So this is quite different to just this normal slight shape variation that we regularly see in Paget's. And the treatment of this is complex and done in specialist centres, few places in the country. Birmingham is our nearest one. And the treatment for that is usually to do a very big prosthetic replacement where you take away all of the diseased bone, and then you have adjuvant chemo and radiotherapy as well. So, but very rare. So in summary, Paget's disease is often end stage by the time it presents to an orthopedic surgeon, usually with joint pain due to arthritis. It can affect multiple areas of the bony skeleton, but may affect just one. And we rely on a close cooperation with our metabolic bone colleagues to treat it, to normalise the disease activity before surgery. And even if the disease is bad, you know, orthopedic surgery is still quite feasible, and the outcomes are generally very good and no different to arthritis from any other cause, provided you use the right prosthesis. But it can be challenging and sometimes require some special techniques. Thank you very much. Any questions?